the war against COVID-19 as more countries start mass vaccination programs. But the World Health Organization warns as rich nations benefit, the poorer ones will be left behind. So, how can we ensure protection for everyone? This is Inside Story. Hello and welcome to the program. I'm Mohammed Jamjoom. The global rollout of COVID-19 vaccines is widening the divide between the world's rich and poor. The United Nations warns what it calls vaccine nationalism is on the rise, as wealthier countries, including the United States and many in Europe, buy up millions of potential doses. The World Health Organization says those with plenty of money have begun mass vaccination campaigns, but criticized them for signing deals with drug makers for early supplies. WHO's Director General urged countries to prioritize COVAX, an initiative to secure vaccines to low and middle income nations.
I urge countries that have contracted more vaccines than they will need and are controlling the global supply to also donate and release them to COVAX immediately, which is ready today to roll out them out quickly. And I urge countries and manufacturers to stop making bilateral deals at the expense of COVAX. No country is exceptional and should cut the queue and vaccinate all their population while some remain with no supply of the vaccine.
On Wednesday, Indonesia and Jordan became the latest to start national vaccination campaigns. Jordan has secured enough doses for a fifth of its population. Its health minister says there will be no discrimination and more than 600,000 Syrian refugees will be eligible. All right, let's bring in our guests. In Johannesburg, South Africa, Helen Rees, Executive Director of the Wits Reproductive Health and HIV Institute and a member of the WHO Strategic Advisory Group of Experts on the COVID-19 vaccine. In the Isle of Wight in the UK, Anna Marriott, Health Policy Manager at Oxfam. Welcome to you both. Anna, let me start with you today. Humanitarians across the globe and NGOs have been urging world leaders to urgently make COVID-19 vaccinations available to millions of refugees, migrants, and others displaced by conflict. Are their calls being heeded?
Well, I think, as you rightly point out, the momentum is growing for those calls for fair and equitable access across the world, because we know that no one is safe from this pandemic until we reach that critical herd immunity across the globe, and that can't be patchy access in some countries and not in others. That continues to put us all at risk if that is the scenario. So far, we're seeing growing momentum for a people's vaccine, for the vaccine science to be shared openly without intellectual property barriers, so that more manufacturers can get on board to produce the vaccine. From many current leaders and former leaders, the President of South Africa, leaders in Pakistan, we're seeing that momentum grow. Unfortunately, we're not yet seeing any big changes on the part of rich country governments. And of course, these are critical players because they're the home to the big pharmaceutical corporations that have developed vaccines that have been approved. We need those governments to call for a people's vaccine, to call on those pharmaceutical corporations to change tack, share their vaccine science and know-how so we can ramp up production and ensure that everybody everywhere, even in the poorest countries, in the most fragile contexts, can access a vaccine.
Helen, South Africa is using the vaccine made jointly by researchers at the University of Oxford and the biotech firm AstraZeneca. Is this going to be a game changer since it's easier to store than the Pfizer-BioNTech and Moderna alternatives?
Well, I think any vaccine that we can roll out at scale at the moment will be a game changer. I think vaccines are a game changer. So that's the first statement. But for South Africa and for the African region more generally, it would be a huge challenge to roll out the Pfizer vaccine, for example, which requires these ultra cold storage temperatures simply because the facilities are not there. And similarly, Moderna doesn't have quite as stringent requirements for storage, but also requires an ultra cold temperature. So certainly the AstraZeneca, which is stable at sort of fridge room temperature of 2 to 8 degrees and stable for a number of months, is a much more viable option in terms of rolling out in our contexts.
Anna, there are growing concerns that the efforts to deliver COVID-19 vaccines to poorer countries, these efforts by COVAX and the WHO, that these face a high risk of failure. What do you say? What's your level of concern?
Yes, we are very concerned too. So COVAX was set up as a global purchasing mechanism on behalf of all countries that want to join, but primarily to serve the interests of the poorer nations who are unable to set up bilateral deals with the vaccine manufacturers. And yes, we've seen those reports too. And our research as the People's Vaccine Alliance have found that for those countries that are entirely dependent on COVAX, 9 out of 10 people in those countries are going to miss out on a vaccine this year. And that is because COVAX is struggling with that supply problem as well. COVAX is struggling to compete with the vaccine deals that are being made by rich countries, which is why we're calling so urgently for this change in tack. COVAX too should be encouraging the pharmaceutical corporations that it's doing deals with to open up their vaccine recipes, to share them with the World Health Organization so that we can get more manufacturers on board in scaling up the production. And then we won't be seeing this this competition, if you like, this unnecessary competition between vaccinating people here where I am in the UK and vaccinating people in South Africa, Pakistan or Bolivia. We don't need that competition if we fix the supply problem.
Helen, there's been a lot of concern, obviously, about the situation in South Africa, this new variant of the coronavirus that's been found to be spreading there. If modifications of the COVID-19 vaccine are needed to address new variants of the coronavirus, is that something that you feel can be done rapidly, or would that take a lot of time?
Well, some of the newer technologies that have so far been shown to be effective, these RNA technologies, the Moderna and Pfizer you mentioned, that can be rapidly changed in a matter of perhaps 6 to 8 weeks. But unfortunately, those are the expensive technologies. Other vaccines as well can be modified, but that might take a little bit longer. So certainly vaccines can be modified. But I think before we jump to that, we need to do all the research that's required to just see how effective the current vaccines are against the variants that emerged in the UK and from South Africa, which, as you quite rightly said, are now globally distributed. These are not just limited to those countries by any means. So I think let's first look at that. We are concerned about one aspect of the immune response, the antibody response, but the priming of the immune response once you have a vaccine doesn't only involve antibodies, it involves other compartments of your immune system. So we're still hopeful that those will work, and we should be pressing ahead with the current vaccines, even in the face of these variants, as quickly as we can.
Anna, let me ask you to expand on that point that Helen was making as well. I mean, how much is there a potential for complicating the rollout of the vaccine with the spread of these new variants?
Well, I think just speaking from a public health risk perspective, there is, and this is an argument that needs to be made again and again, that the longer that this virus is allowed to continue in parts of the world, the risk of those mutations will increase, which could, which risk rendering the vaccines that we have, including those ones that are more suitable for developing country contexts. It risks rendering those ineffective. And if we're already struggling with supply, with production of these vaccines at the scale required, if those modifications have to be made, or even if we have to go back many steps in the design of these vaccines in order to respond to these mutations, then we're setting back our supply even further. So I think that the message that I would like to get across is about the need for urgency and speed in the production of these vaccines, so that we can avoid those mutations as much as we possibly can.
Helen, I want to ask you something else regarding the new variant of the coronavirus in South Africa. Do you know how far it has spread throughout the country? Is there growing concern there that it could become the dominant variant there?
It already is the dominant variant, and it happened extremely quickly. If there's sort of lessons to be learned, one of the triggers for its spread were mass gatherings, which were associated with the holiday period. But it has taken off, and it has become the dominant variant in the country. And early indications would suggest that it's also spread, because this is the equivalent of the Northern Hemisphere summer holidays. That's what we've just had. And many people are migrant workers, and they go back to their homes in places like Zimbabwe or Botswana. And early indications would certainly suggest that this variant is going to quite rapidly spread beyond South Africa's borders.
Anna, since there are growing calls to ensure that vulnerable and marginalized populations like refugees, like IDPs, like migrants, that they, can be assured getting access to the vaccination going forward, I want to ask you about the logistical difficulties of getting COVID-19 inoculation programs to refugee camps. I mean, when we're talking about refugee camps, I've spent a lot of time reporting from refugee camps around the world. There are official refugee camps like Zaatari in Jordan, and then there are unofficial refugee camps like what you see dotting the landscape throughout parts of Lebanon. Depending on what kind of refugee encampment or displaced person encampment you're talking about, that really can change the level of difficulty on something that's already challenging, right?
Absolutely. I think that really goes without saying. It really speaks to the design of these vaccines as well, in terms of comparing the technologies used in these vaccines with Oxford University. I think should receive welcome praise for the fact that from the outset of the design of these vaccines, they wanted it to be a globally accessible vaccine, so that it didn't require extreme storage or extreme cold temperatures, most So there is a problem in the design of these vaccines that we would like all vaccine manufacturers to be thinking about those most difficult environments in which these they need to be deployed. And yes, the circumstances in those refugee camps are extremely challenging. Organizations like UNICEF, like MSF are at the forefront of efforts to ensure that those logistical challenges can be overcome, but it's certainly not without challenges. And because so many people within these fragile contexts, within these refugee camps, are not necessarily, or as you say, outside of formal refugee camps, are not necessarily recognised as citizens, or not recognised as the responsibility of any individual government, it's incredibly important that when COVAX is developing its deployment strategy, when the World Health Organization is looking at this, when rich country governments are securing their vaccine deals, that everybody looks to ensure that we have sufficient supplies for those populations that are not going to be covered by individual governments, and that organizations like MSF, like UNICEF, have enough vaccines to deploy in those contexts, and that the financial support is there necessary to overcome those incredibly difficult logistical challenges.
Helen, from your vantage point, are you seeing procedures being put in place right now to ensure that vulnerable communities like refugees, like displaced persons, are going to have access to the COVID-19 vaccine in the near future?
It's a very good question, and I think governments are rushing to try and prepare just national plans. But one thing I would say is that the World Health Organization some months ago put together the committee you mentioned that I work with, and for the first time there were principles spelt out about the distribution of vaccines that were ethical principles. They were global ethical principles to say these are the principles that must drive our decisions. And then after that, those principles were applied to who we should be prioritizing. Clearly, one of the groups that many countries have prioritized are healthcare workers. And that's because they are at such high risk, particularly where you don't have good protective equipment. And that if we lose our healthcare workers in many settings, we don't have as many as in richer countries. If we lose them, not only are we not able to look after COVID patients, but we're not able to look after patients, for example, who are pregnant and delivering, and et cetera, et cetera. So those principles, those ethical principles were applied. And one of the things that came out very loudly was that we should take into account people's vulnerabilities. So it can be their comorbidities that will be talked about a lot, the diabetes, high blood pressure, obesity. We've talked about that a lot. But the vulnerability can be that you are having to live in spaces that are extremely confined and that you cannot possibly get away from. I was listening on the radio locally here today about a family with 47 people in the household. You can't socially distance. You can't physically distance under those circumstances. So we need to think about vulnerabilities beyond the medical, and we need to think about those who are extremely vulnerable just by virtue of where they rest in the social order.
Helen, I mean, if these efforts to deliver COVID vaccines to poorer countries fail, I mean, you're talking about vulnerabilities. If these efforts fail, at least in the short term, how much worse could the situation get?
Well, if they fail, we're not going to be able to break this pandemic. It's as simple as that. And I think worldwide, whether you're a rich country or a poor country, everyone is now suffering from second waves, third waves. Everyone is seeing the threat of health services being overwhelmed and healthcare workers now being totally fatigued because they've been at this for a year now. So this is a common experience, no matter where you are. And if we don't actually get vaccines equitably to all who need them in the world, it'll have to be obviously in a tiered order, a prioritized order, because we simply don't have enough vaccines or capacity to roll out to everyone all at once. But if we don't do that, if you, for example, you leave the African region out, then we will see what happened in the pandemic flu of 2009, where we had vaccines. Rich countries purchased most of those vaccines, and very, very few vaccines ever made it to this region. And when we got them, it was too late. Now, if we do that and we leave out low middle income countries, then the spread will continue. We already do know that there are many people, for example, in the US or even in the UK, who are choosing not to have vaccines for a variety of reasons. That means you're not going to have 100% vaccine coverage. You will have susceptible populations, even if you've got high coverage, high attempts at coverage in your country, and you're able to do that. As long as you have susceptible populations in that manner, and as long as other countries don't have access to a vaccine, spread will continue. We've seen that with these new variants, which are emerging all over the world now, we are probably going to see increased transmissibility. And that means that spread will be much easier.
Anna, two of the points that Helen was touching on in her previous answer are vaccine nationalism and vaccine hesitancy. And I want to ask you, from your perspective, how big an obstacle each of these concepts are when you talk about vaccine nationalism in trying to combat the spread of COVID-19, and when you talk about this growing anti-vaccine movement, this vaccine hesitancy that we are seeing getting, essentially growing throughout the world.
Yeah, well, I think in terms of the vaccine nationalism, we have, I think, what is a toxic mix at the moment with supply constraints, artificial barriers to the production or the increased production of this vaccine, combined with vaccine nationalism, which therefore, directly means that we have limited supply. And if rich countries are buying up more than they need of these vaccines to spread, I mean, they are acting in many ways as you would expect them to act. Those governments have priority responsibility for the people that live within their borders. It's quite a natural response of governments to want to purchase as much as possible, to hedge their bets on as many vaccines as possible, in order to be successful in protecting their own people. So I think it's politically very difficult to suggest that people in the UK should relinquish the vaccines that they have, although it is also really important to get the message across that if we had fairer distribution across the world, the evidence suggests that even of that more limited supply, the evidence suggests that deaths overall from this pandemic would decrease. But I think that vaccine nationalism is a massive problem precisely because we have limited supply. So I come back to that point about maximising supply so we don't have this false competition. And on vaccine hesitancy, yes, it's a significant problem in countries like France. The vaccine hesitancy has become an enormous problem. And I think the only thing we can do about tackling that is for clear, transparent data, clear messaging, so that people are fully informed about the evidence base around these vaccines, the processes that they have gone through to acquire regulatory approval. We're not yet seeing the level of transparency from the pharmaceutical corporations about their own data that I would like to see, that I think governments need, and to be communicating to populations so that people fully understand the benefits, the possible side effects, of these vaccines, but so that people can make informed choices to take these vaccines.
Helen, it looked to me like you might have wanted to jump in. Go ahead.
No, I mean, I would echo what Anna has just said, but I think that one of the things we need to think about in combating the anti-vaccine messaging is, I mean, again, we're seeing the power of social media here, because certainly if I look in our region, some of the messages that are coming through didn't originate in South Africa. They came from other spaces, but they quickly get adopted. So, you know, the thought that there is a conspiracy behind vaccines is now widely held. And we really do need to think how we combat that. There's also, as you know, been a sort of undercurrent of anti-science over a number of years. So how do we regain people's trust in science so that when scientists say something, that people say, we trust that individual, we trust what they're saying, because that's what needs to happen here. But we certainly need to think, and each country will have to do its own diagnostic on why people are hesitant about vaccines. What the diagnostic for France would be somewhat different to a diagnostic in South Africa.
Anna, we've spoken a lot today about what would happen if things go wrong. I want to try to look at what might happen if things go right. The WHO is administering this rollout to poorer nations. They aim to have 2 billion people vaccinated by the end of 2021. How ambitious is that? And from what you've witnessed thus far, do you think it can be done? What has to happen from here on out for that to be accomplished? So
I actually think that target of 2 billion is not ambitious enough. And I think we can achieve more if we change tack. You know, we're talking about, you know, countries in the UK, government here is you know, saying that we'll be achieving significant rollout of this vaccine by Easter, by mid-year, so that we can enjoy looking to an escape route from this pandemic. It should be no different for any other country. You know, the right to health is equal across the planet, and we do have the means to get there. The manufacturing capacity that has been reported by all the vaccine manufacturers across the globe suggests that we do have capacity to make enough vaccines if it's deployed in the right way, if the science is shared. And I think a really good development yesterday was that Dr. Fauci, you know, a recognizable leading doctor on infectious diseases and advisor to the government in the United States, yesterday lent his support for the pooling of vaccine science and know-how, lent his support to the World Health Organization's COVID technology access pool, which is the mechanism we need now to be championing and ensuring that pharmaceutical corporations are sharing their science. I think we can massively scale up production if we have a significant change in TAC.
All right, well, we have run out of time, so we're going to have to leave the conversation there. Thanks so much to our guests, Helen Rees and Marriott. And thank you, too, for watching. You can see the program again anytime by visiting our website, aljazeera.com. And for further discussion, go to our Facebook page. That's facebook.com/AJ Inside Story. You can also join the conversation on Twitter. Our handle is @AJ Inside Story. From me, Mohammed Jamjoom, and the whole team here, bye for now.